All right, here we go. It's Thursday, 5 o'clock. You know what time that means. Dr. Brandon Money here at the Centeno Schultz Clinic, the top five golf guy, where we are going to go over the top five lumbar spine related golf swing injuries, not just related to golfers, because lots of individuals that don't golf get this stuff every single day. That's why we're here. That's why we take care of our patients. Let's get into it. So, a little bit about me. I am board certified by the American Board of Physical Medicine and Rehabilitation. I am fellowship trained here in interventional orthopedics or interventional orthobiologics at the Centeno Schultz Clinic. I am also certified by the Titleist Performance Institute. Um, and TPI for short is a network of golf teaching professionals, physical therapists, chiropractors, physicians, other experts with additional training and really how the golf swing and the human body work together. Also a golf enthusiast, as you would expect. My wife would probably use the word obsessed, but I prefer enthusiast. And there's my Instagram, Golf Talk USA. If you want to peruse and learn a little bit about me, my personal life, my golf-related life, so on and so forth. And just to toot my own horn a little bit, last week there is a group of 20 friends of mine that we all get together every year to different locations. This year we were at Big Cedar Lodge and we make a big golf tournament out of it. And I was fortunate enough to be on top at the end of the weekend and defending my crown from 2023. So there's me holding the trophy on the last hole with a beautiful sunset in the back. And I think I have some matching shorts there to match the sunset. Was not planned that way, but that's okay. All right, so let's a little bit about lumbar spine anatomy. So lumbar spine has a lot of things going on. And there's five lumbar vertebrae bones. We also have the sacrum. We have the pelvis, which is what wraps around our body. Right in the middle, we have joints. We have facet joints. We have sacroiliac joints. We have pubic symphysis. We have many muscles and then, of course, tendons as well that help provide movement and stability. Many ligament structures to help provide stability with movement so those bones aren't moving around on each other. And we also have the intervertebral discs, which help provide rigidity and cushioning between those individual vertebrae bones. And so this background graphic here is actually one of the better Chat GPT AI created anatomical images. It is still quite inaccurate if you look at it in detail, but it looks good and is far better than most that I see. I just don't want any anatomy students to utilize this for any of their anatomy exams because your performance will greatly suffer if you rely on this for the anatomical structures. Okay, let's get into the top five for golf swing injuries, lumbar spine edition. And this one was actually quite difficult to narrow it down to only five just because of the complexity of the lumbar spine, the complexity of the lumbopelvic area, and the variety of conditions that we do find in patients. Number one, by far, degenerative disc disease. It is the most common golf related symptom. About 50% of golfers will experience symptoms related to this at some point in their golfing career. Low back pain, degenerative disc disease results in hundreds of billions of dollars in all-cause medical costs every single year here in the United States. It's usually related to chronic breakdown of those spinal structures, but it can also be accelerated by a traumatic event. So, falling down the stairs, car accident, high velocity, ski accident, falling down a mountain, things like that can accelerate the symptoms related to degenerative disc disease. And we know as we get older, tissues become stiffer and they break down, and how our body looks at 17 is a lot different than how it looks at 47 and 87. So, degenerative disc disease doesn't necessarily mean you have to be in pain, and it doesn't determine the significance or the severity of pain. So we get instability in the spine due to disc degeneration, laxity of ligaments or injury to ligaments, weakness of muscles, and basically instability means those bones are moving around more than they should on each other. The facet joints themselves can become arthritic, enlarged. We get bone spurs that get created because the body is trying to help with that stability. So it says, hey, let's add more bone here. Let's add more bone here. If these bones touch, things won't move around as much anymore. And so the central canal can narrow, which can compress nerves, which is part of what we're seeing here in this MRI scan. So here we see pretty significant degenerative disc disease, disc bulges that are sticking out. Not going to go into all the details, but this is one of the more severe uh, images that I found. And this is a patient that I saw not that long ago, just a couple weeks ago. And shockingly enough, this patient's approaching 70 years old. They're still very active. They still lift weights. They still participate in sports. They still get on the track and do sprints, and as well as the football field and all of this. And if you just look at the picture and say, how are you able to do that? Well, that's why we treat people. We don't treat pictures here at Centeno Schultz Clinic, because we know most middle-aged and elderly adults are walking around every day with degenerative disc disease and they don't even know it. Studies have shown that upwards of 37% of 20-year-olds and 96% of 80-year-olds have image evidence of this condition we call degenerative disc disease. And that's why it's so important to not get fixated on what the images look like rather than actually listening to the patients and their symptoms that they have. And so when talking about the instability, as a body part gets unstable, it can further worsen the joint degeneration. So let's think about a loose lug nut on a wheel of your car. If you're a patient of mine, I know you've heard this. And so you drive that car with a loose lug nut for a mile or two, probably not a big deal. However, if you neglect that and wait a couple oil changes to get that addressed, well, then you're going to be talking about steering issues, suspension issues, alignment issues. All of that can be going on. Okay, number 2, disc herniations. And so, what I want you to think about the intervertebral disc is kind of a jelly donut that's wrapped inside of an onion. This might be saying, Dr. Money, why are you talking about two very different foods? Because the inside of the disc, or the nucleus of the disc, is a fluid-filled microenvironment. I want you to think of it like a snow globe. It has its own environment in there. It's isolated from the outside world in a normal disc. And there's many different proteins and bacteria that have a particular balance of these in a normal disc. And so the outer shell of the disc, the annulus, is tough layers of collagen and proteins to shelter that annulus from the outside world. Pardon me just one moment. There we go. Okay. Had to answer a patient call real quick or send a text message about a patient. And so weakness or injury to that annulus can cause that disc to protrude or herniate. So if we look at that big red sign on the image here on this slide, we can see how that is pushing out. That little yellow stalk that's coming off of the middle is the nerve. And so that can compress the nerve root and direct trauma to those adjacent nerves. And so there's different stages of disc herniation. It's like saying the word car, a million different kinds. We got Ferraris, we got Honda Civics, we got Porsches, we got F1 race cars, Indy cars, all of that. Many, many different kinds. And so the vast majority of patients that I see have likely had changes in the disc a long time before they've ever gotten any imaging, before they ever got any symptoms. Again, these findings are very normal as we continue to get older. And so many are very common. They're asymptomatic in nature, but if they get to a certain size or a certain shape or a certain position, they can compress those adjacent nerve roots. And then very, very rare, you can actually have a piece of that disc kind of break off, and then it's just floating around there in the spinal canal. But that's very, very uncommon. I may see one of those a year, probably at most. Okay, number 3, facet joint arthritis. And so what is osteoarthritis? It's a very complex condition. It's more than just the loss of cartilage in a joint. What I often say to patients is that that's basically what it is, because it is, and we don't have to get into all the details about it, but there's biochemical, biomechanical, structural changes that can ultimately cause dysfunction and pain. And so as a result, it can't really simply be described by a single definition. And so, what are the facet joints? They are what connect the bones of the spinal column, those vertebral bones, on top of each other in the back part of the spine. And so, on the front part of the spine, it's connected by those discs that we just saw. And so in the background here, top left, we can see a pretty normal facet joint. So the joint space is the dark curved structure, one on the left side, one on the right side. And then as we progress down to D, I know it's tough to see, but we can see changes in the joint space itself. We can see extra pieces of bone that are being made, bone spurs. And so, do those bone spurs need to be removed? Well, 99.9% of the time, no, because they're not necessarily doing anything. If they're not getting in the way and they're not causing symptoms, then just let them sit there. I think the risk would outweigh the benefit of going in there and removing something like that if we don't necessarily need to. Okay, so facet joint osteoarthritis, a study that was performed on cadavers, whether they went into cadaver tissue and looked at those facet joint changes directly. 57% of those in their 20s had these changes. If you're 60 or older, congratulations, you got it, according to this study. Facet arthritis is usually a finding related to degenerative disc disease or DDD, not solely a facet joint issue without any other imaging findings or symptoms related to that. Very uncommon that it would be just isolated to the facet joints themselves. And this picture here is an MRI scan. The facet joints, we see this bone that looks like a Y bone in the middle of the screen. And so we're looking at the left and right tips of the Y bone, very arthritic joint. You can see how they're not symmetrical too much anymore, and just a pretty deteriorated spine overall. Okay. Now, number 4, central canal stenosis. I'm sure most of us, if you're watching or will watch, have heard of stenosis before. Different kinds, but stenosis in layman's terms just means narrowing. There's an open space. That open space decreases in size. And so the central canal here in the middle of these two images here are where the spinal cord travels down, as well as the nerves exit off the spinal cord. If we're low enough in the lumbar spine, the nerves will travel down and then ultimately exit. In most patients, the spinal cord itself ends at about the L1 level, which is the very top of the lumbar spine. But we have all those nerves that ultimately go further down. That's all these little yellow dots that we can see in the middle of the spinal column here in this photo. And usually central canal stenosis is a result of chronic, again, degenerative disc disease related changes. And so changes often include slippage of the bones forward and backward on another, either due to trauma, instability, arthritis of the facet joints, bony overgrowth can impede the amount of space where those nerves live and travel, disc bulging, disc degeneration, just like we can see here on the right side. We have that disc herniation that's decreasing that space, thickening of the ligamentum flavum, which is a ligament that helps protect and stabilize the spine. As there's instability, that ligament can get thicker, which effectively is going to decrease that space where those nerves and spinal cord travel. And oftentimes, we don't get, patients don't get symptoms unless it's more advanced in nature, or the symptoms are tolerable where they don't think about, hey, let's go get some imaging, let's go see somebody. Okay, now we have some color on this MRI scan here. So we'll go through it momentarily. So compression of the lumbar nerves can result in either unilateral, most commonly bilateral, meaning both legs, both sides of the back, pain down the leg, numbness, tingling, burning. You have difficulty standing upright and you feel like you need to lean forward, and that helps relieve your symptoms. Think about how someone looks when they're pushing a grocery cart. Lots of individuals that have central canal stenosis that's symptomatic, they often try and walk in that position where they're flexed a little bit forward in their upper body to help relieve and open up that space. And so the colors here, we have our pink color, which are the facets, the facet joints in the middle and the bones that surround it. And here you can even see how asymmetric on the right side of the picture, which is the left side of the patient's body, compared to the other side. So we're getting some bony overgrowth there on the bottom of it. The green V shape is the ligamentum flavum. It's a little bit thickened in this patient, which helps contribute to that stenosis. The yellow that we see are all those nerve roots. So if I remove the yellow, you would see a bunch of little dark gray dots, which are the actual nerves that are ultimately going to exit from there and go down the legs likely. And then we have the a misshapen circular structure, just because I can't freehand draw to save my life. That's why I became a physician. That's the actual disc itself. Okay, next. 5, sacroiliac joint and dysfunction of that joint. So this SI joint, we have two of them, one on the left, one on the right. That's these two yellow circles at the top of this graphic. That's where the sacrum meets the pelvis on the back side. But we can't forget about the pubic symphysis, which is the joint in the front. So making up our pelvis, we have 3 joints, 2 in the back, 1 in the front. And if we have dysfunction on one, then we may have dysfunction on the other. So you at least need to check it out. And so these joints can be very hypermobile, especially post childbirth, because we think as mothers and babies go through the delivery process, we have to have a large baby that goes through a small canal, and those joints have to expand and those ligaments have to get stretched out in order for the birthing process to happen. The SI joint has multiple contours. It's a very wavy structure, which, if put out of alignment by a small amount due to instability, due to trauma, you name it, that can certainly cause patients pain and irritation of that joint. Okay. Now this is a picture on the left that we see from the backside. So that's like looking at somebody's back of their body. And so all of those little white bands we see are all ligaments that surround that joint. We have all these lumbar ligaments that help provide stability. And so again, if those ligaments get stretched out or loose, doesn't necessarily mean they're torn or damaged to an appreciable degree, but they can certainly get stretched out and create instability around that area. And so if you've had a previous fusion in your lumbar spine, we've got to think about adjacent segment disease. And what does that mean? That's increased movement when we're talking about the SI joints, due to a lack of movement from those bones that are screwed together. And so we know that the SI joints have to move more in order for your body to be able to move. And so that can certainly create dysfunction, pain, accelerated osteoarthritis, and lots of different things. And we don't necessarily get that just in the SI joints. We can get it both above and below the levels that are fused, because your body's still going to move. Your body still has to move. The goal of the fusion is to make those bones not move anymore. And so something has to give, and that goes above and below. So now that we've identified the top 5 commonly seen lumbar spine injuries in golf, what the heck do we do? Well, before we get to that, we're going to talk about a little bit related to golf specifically, because before now, it could be anybody that has back issues. This is more directly related to golfers and the golf swing itself. And so we know that certain golf swing characteristics can either have an increased likelihood of back pain or hip pain or neck pain or whatever it may be, or the conditions that you already have in your lumbar spine can help contribute to the swing characteristics that you have. We all have a different golf swing for a million different reasons. And very often we find that issues in the low back can create certain swing characteristics. And that's what we identify as TPI professionals. And so if you have facet joint pain, you probably don't want to early extend, because as we get into that extension position, that cramps down those facet joints. It can make them very angry. And so if your hips aren't very mobile due to a number of different reasons, that can increase the stress and movement on the lumbar spine, because your body still has to move during the golf swing, has to go back, has to go through. If the hips aren't doing their job properly and moving, then the lumbar spine's got to do more, which can certainly create symptoms. Hip mobility is very key in the golf swing. And so if that's compromised, then the lumbar spine just has to work more just to be able to swing a club. And so if you have that central canal stenosis, then you may have more lumbar flexion. You may be hunched over a little bit more than the average golfer in the average golf swing, simply because you don't like to be in that erect, upright position. So kind of the opposite of that facet joint pain, in that you don't want to get into that position, or similar to facet joint pain, because it feels better when you're flexed a little bit more. And so now, what the heck do you do? So this is the insider approach. This is what the experts do. This is what The top golf professionals in the world, nearly all of the top golf professionals work with a TPI expert. There's a reason why the pros choose them. They can choose anybody in the world. They can go travel any country, any place in the world, and get evaluated, get treated. So there's a reason why they see TPI experts, because we've been trained on how the golf swing relates to various conditions. And so you want to find a physical therapist, you want to find a chiropractor, you want to find a physician, you want to find a golf professional that is certified by the Titleist Performance Institute. And so you can go to mytpi.com and check it out. All those are listed on the website. And so easy things, weight loss. If you're holding excess weight, get rid of it. However you need to do that, get rid of it. We know it doesn't do you any good. Lifestyle modification. So making sure our diet's in tune, making sure we stop smoking, making sure we cut back on alcohol, any other toxic substances that we put in our body. Do those things first. If you're not getting anywhere and we've identified issues, then you may need to consider some orthobiologic type treatments such as PRP or bone marrow concentrate or prolotherapy to help promote tissue healing and repair. And so what you want to avoid are high dose cortisone or corticosteroid or steroid injections. They all have different names, but they all mean basically the same thing. So high dose steroid injections have been shown to help accelerate arthritis progression, create worse injuries in tendon tissue. And then, of course, surgery is always going to be your last resort. All right, moving on. So let's talk a little bit about PRP. What is PRP? PRP stands for platelet-rich plasma, as I just mentioned. And so what we do here at the Centeno Schultz Clinic and as part of the Regenex Network, we take those platelets from your bloodstream. Everything comes from you, doesn't come from anyone else, doesn't come from amniotic or fetal tissue or any related to that. And we're able to concentrate those platelets to a much higher concentration than what you normally have in your body. And so there are growth factors or healing factors inside platelets. Think about a platelet like a piñata at a kid's birthday party. The kids don't care about the piñata. They want the candy that's inside that. And so that's where the candy is. That's where the healing factors are. And those healing factors, they help stimulate the body's natural healing processes. They help boost tissue repair and healing. If I had to give a one-sentence explanation of why we do what we do here, we just try and get the body to help heal itself. That's it. There's no magic fairy dust out there that's going to turn you back into a teenager again. But we know we don't need that for you to feel better. And that's ultimately what matters in the grand scheme of things. And so here at the Centeno Schultz Clinic, we focus on neuromusculoskeletal conditions, tendon issues, ligament issues, bone issues, joint structures, or a combination. And these are used every single day in our clinic. I can't even count the number of procedures I had today, 5 or 6 or something like that. But okay, moving on. So I want you to be careful. These are some caveats that you really need to be aware of. And so not all PRP is the same. Dosage is key. You want the adequate dose that is for you, your condition, your body. There's no cookbook for this that says this is page 47. This is the lumbar spine page. This is the knee page. This is the shoulder page. This is what we do. Your body is different than everybody else's. You need a treatment that's dedicated strictly to you. There's too many clinics out there that promote that they do PRP. They don't have adequate training. They don't have adequate safety protocols. Safety is key. Safety is my number 1, 2, and 3 priority. If something's not safe, I'm just not going to do it. Too many people out there are doing blind injections without image guidance. So if you're not using ultrasound, if you're not using x-ray, you might as well just be throwing a dart at a dartboard with turning your back the other way, because you don't know what you're going to hit. That's very, very crucial. You need to do your homework. Are you going to see the doctor? Are you going to talk to the doctor? Is the doctor going to be doing your procedure? Or is it going to be their nurse practitioner or physician assistant? Don't get me wrong. They're great providers. My wife is a PA, but non-physician providers, they don't have the training, the education, the expertise necessary, not only to do the procedure, but just to be able to diagnose your condition appropriately, because that's way more important than just doing the procedure. Because we have to figure out what's going on and what's the best way to approach that. And so the best in the world, they have specialized orthobiologics training. They're certified by the Interventional Orthobiologics Foundation. They've gone through courses, they've gone through workshops, they've gone through lectures. They have hands-on training and experience knowing what to do and how to do it most appropriately. And so some questions to ask. This is going to be a little foreshadowing, because I think I'm going to do my next top 5 based on top 5 questions to ask your orthobiologics provider. And so how's the PRP prepared? Do they process it by hand? Do they have a machine that looks like a printer that sits on a desk over here? And they draw a little bit of blood. They put blood in there and it spits out something that's supposed to be PRP. How concentrated is it? Are there red blood cells? Are there white blood cells? What's in it? They have no idea. Because these machines don't test. That's why we have a lab that's right across from my office, right through here, where we have 4 people working there at all times, and their job is to process it to the specifications that the physician orders for the individual patient. And so what type of image guidance is used for the injections? Again, are they just blindly throwing a dart at a dartboard with their back turned? Or are they actually using ultrasound and or a combination of ultrasound and X-ray in order to know exactly where it needs to go? Because these cells, these platelets, these healing factors, they don't have a magic homing beacon to know where to go. You've got to put it exactly in those structures in order for it to have that healing response. And which structures are being treated, and why are they treating those structures specifically? Are they just going to go into the joint? Did they even assess the ligaments? Did they look at the tendons at all? Did they do a diagnostic ultrasound to be able to get a good look at your knee, your shoulder? Did they look at your MRI or X-rays, the actual images, not just going by the report that the radiologist wrote up? What other options are available to you aside from PRP or orthobiologics? You need to have all the information so you as a patient can be the most educated possible. So that way you can ultimately make the best decision that's in your best interest. And also, did the physician undergo specialized orthobiologics training and or fellowship? Me, before I started doing this, I did an entire fellowship for a year here at the Centeno Schultz Clinic before I got set out on my own, because it takes that long to be able to learn what's going on and how to do it properly. All right. A little bit about our clinic here at the Centeno Schultz Clinic. We're based out of Broomfield, Colorado, suburb of Denver. We're the world leaders in orthobiologics treatment for musculoskeletal conditions. We invented many of the procedures that are used across the globe. We do constant research. We constantly evolve our procedures. We constantly evolve our lab techniques to help build better products to ultimately give the patient the best opportunity to help heal. And that's what we do. We maximize the body's own ability to help heal itself. So we use a variety of different tools available to us in order to do that. And so one patient might receive bone marrow concentrate as their treatment. One may be PRP. One may be prolotherapy. One may be a combination of a lot of different things. I would say most patients are probably a combination of a lot of different things. And over the years, we've published multiple studies using orthobiologic-based treatments for lumbar-specific issues. And we're actually currently recruiting patients for a study involved in degenerative disc disease. How fitting. So if you have back pain, if you have degenerative disc disease, if you've been told by a surgeon you need a fusion or you need surgery, you may qualify as a study patient for treatment. So if you post a comment, we'll have one of our staff members get you in touch with our research team so they can go through some of the inclusion, exclusion criteria, all that kind of stuff associated with research studies. And so some final thoughts here. The golf swing's complex. They're all individual. I don't know a single 2 people that have the same golf swing. I mean, heck, I'm left-handed. We represent 8% of the golfing population. So the other 92%, my swing is totally opposite. It needs a specialized evaluation and plan. We have to know what's going on, and we have to know how to adequately treat it. We start conservative. We start with the easy stuff: the weight loss, the diet, the exercise, the physical therapy, chiropractic, so on and so forth. And then if you're still not where you want to be, we move up the chain as far as intensity, because as we get more involved, as we get more invasive, there are increased risks associated with that, with surgery being at the very top or the very end. That's the most risky. And so you don't jump straight to surgery if you haven't tried all the other stuff, by and large, in the vast majority of patients, barring any major severe conditions. Beautiful thing about medicine is you never say always and you never say never. And really, it's all about progress, not perfection. We want you to continue to improve, and it takes time to allow that to happen. We want you to get on the road to getting better. You're not going to wake up the next day after a procedure and feel like you did when you were a teenager. I wish I'd be first in line. I'd get treated every day if that was the case. If you want to learn more, if you have questions, I want you to visit our website at the Centeno Schultz Clinic, centenoschultz.com or regenx.com. Tons of blogs, tons of webinars, tons of information about that. And yeah, so if you get really bored and you want to read the research papers associated with this, there's some details for that. But if anybody has any questions, thank you for the comment. We appreciate it. Um, Everybody take care, and we will see you next time. Stay active, stay healthy. If you're a golfer, enjoy the dwindling down of the summertime. Hopefully it's nice and cool and at least tolerable where you live. But we'll see you next time. Take care, everybody. Bye.